We would like to begin by acknowledging the traditional owners and custodians of the land on which we are presenting today, the Wurundjeri people of the Kulin Nation. A good health system is defined by the World Health Organization as one that delivers quality services to all people when and where they need them, thus promoting, restoring and/or maintaining health. The Australian healthcare system is complex and consists of a network of services, providers, receivers and organised structures in both public and private health sectors. The Australian healthcare system can be categorised into three aspects: primary healthcare, secondary healthcare and hospitals. Let's take a further look into the different sectors of the Australian healthcare system. Medicare, which was first introduced in 1984, makes part of the public sector in the Australian healthcare system. It is Australia's public health insurance scheme that provides universal subsidised access to primary healthcare to all Australian citizens and permanent residents. When health professionals accept Medicare cards as full payment of a service, they are charging Medicare directly rather than the patient. This is known as bulk billing, as outlined in the Medicare benefit scheme. The Medicare benefit scheme covers consultation fees with most general practitioners, tests and examinations such as x-rays and pathology tests, eye tests conducted by optometrists and some surgical procedures performed by doctors or dentists. It also covers the costs associated with seeing a general practitioner in a public hospital. In order to provide a high level of healthcare at an affordable cost, the Australian government introduced the Medicare levy. The levy is set at 1.5% of an individual's taxable income unless they are a low-income earner. Additionally, any single person or family who earns a higher income and does not have suitable private health cover are charged an additional 1% of their taxable income. One of the biggest strengths of the Medicare benefit scheme, which is a component of Medicare, is that it provides rebates for medical and hospital services to all Australian residents. However, a weakness is that it does not cover costs for secondary healthcare services or complementary and alternative medicines. For private hospital treatment covered by private health insurance, 75% of the schedule fee can be claimed back. Excess amounts of the rebate that are paid may be claimed under private health insurance arrangements. The Medicare benefit for out-of-hospital services is 100% of the schedule fee for non-referred GP attendances. Private health insurance is not compulsory, however it does support Australia's public health insurance scheme. It is available to those who wish to have full or partly covered costs of being admitted to hospital. The Medicare benefit scheme and pharmaceutical benefit scheme are beneficial to private patients as the Australian government also covers costs associated. Those who have private health insurance can choose the level of cover they want depending on their own personal situations. Private health insurance differs from public health as it covers the cost of other health services such as ambulance services, dental services, prescription glasses and physiotherapy. It also allows for a private patient to have more choice in how they want to be treated in a hospital in regards to being a public or private patient, which in turn determines their waiting time.
Now we're going to move on to the pharmaceutical benefit scheme. So the pharmaceutical benefit scheme, PBS for short, began as a limited scheme in 1948 with free medicines for pensioners and a list of 139 life-saving diseases preventing medicine free of charge for others in the community as well. The PBS is governed by the National Health Care Act of 1953, and the PBS is also managed by the Department of Health but administered by the Department of Human Services. Under the scheme, all Australian residents who hold a current Medicare card are eligible, and under this scheme, the government subsidizes the cost of medicine of most medical conditions. Most of the listed medicines are dispensed by pharmacists and they are used by patients at home. The aim of this policy is to meet medication and related services needs so that both optimal health outcomes and economic objectives can be achieved. Today, the PBS provides timely, reliable, and affordable access to necessary medicines for all Australians. The PBS is part of the Australian government broader national medicine policy. One of the benefits of the PBS is that overseas visitors from countries with which Australia has a reciprocal health care agreement are also eligible to access this scheme. And then it is basically cost cutting. And the PBS is able to cap costs or control costs in any number of ways. For example, by simply capping the budget or the PBS budget. And just as clearly, different levels and loci of cost reduction will have different impacts on the PBS. Some of the work that still needs to be done is that even though the mission of the PBS is to make drugs affordable for all Australians, there is still a need for responsibility of cost in the community. The currently growing cost to the community of the PBS is placing a pressure on its future capacity to make available these drugs that all Australia needs, especially newly developed expensive medicines. The sustainability of the PBS is consequently an issue of some importance. Now Isaac is going to talk about the rural health.
Rural and remote Australia refers to those areas outside of major cities defined by several different geographical classifications. Australians living in rural and remote communities experience relatively poor health status in comparison to the wider Australian population. This represents a significant weakness in the Australian healthcare system, as approximately 32% of Australia's population live outside major cities, and they have death rates that are 1.7 times higher than those in more metropolitan areas. Indeed, health becomes worse as remoteness increases. This is partly related to the greater numbers of Aboriginal and Torres Strait Islander people in remote areas who experience poorer overall health outcomes. Indigenous health represents a significant weakness in Australia's rural and remote health network. In 2011, around two-thirds of Indigenous people did not live in major cities, meaning that addressing Indigenous, Aboriginal and Torres Strait Islander health outcomes will go a long way in improving the overall health of rural Australians. Key Indigenous health issues include low birth weight, lower life expectancy, cardiovascular disease, especially for those in remote areas, and diabetes, which is also a more significant problem in rural communities. Compounding all of these health issues is the fact that only 1% of people in the health workforce are Indigenous. Poorer health outcomes for general rural communities can be due to many factors, which can include generally having older population groups, average lower levels of income and education, poorer physical and financial access to services, higher occupational and environmental risk causing an increase in injury rates, and factors unique to Aboriginal and Torres Strait Islander health. Access to healthcare services is the major weakness of rural health. In 2004, the Australian Medical Association estimated a shortage of 430 full-time medical practitioners to Aboriginal and Torres Strait Islander people alone. However, rural and regional health services and the staff and volunteers who work within them have strong relationships with the local communities in which they are located. This is a strength of rural healthcare which contributes to the economic viability of many rural and regional towns and assists to build the social fabric of the local community. Despite the shortcomings in rural health, there have been improvements. For example, in 2011, $4.6 billion of Australia's health expenditure was spent targeting and improving Indigenous health. And between 2001 and 2010, 21% fewer Indigenous Australians died from preventable causes. There are also many existing policies which aim to reduce the inequality of health services provided to rural and remote communities. These include Commonwealth and state governments offering scholarships in medicine, nursing, pharmacy and other health professions who study in rural locations, 25% of medical students who are required to spend a minimum of 1 year in rural placement, supplementing the medical workforce through international medical graduates and overseas trained doctors, the National Rural and Remote Infrastructure Program, a program which supplies essential infrastructure and equipment needs to rural and remote communities, the Royal Flying Doctor Service of Australia, which provides services including supplying pharmaceutical and medical supplies, 24-hour emergency service, primary and community healthcare clinics in remote areas, and consultations with a doctor or nurse through telephone or radio. Other programs include the Rural Women's GP Service, which enables women to consult a female general practitioner who are funded to visit rural communities, the Visiting Optometrist Scheme, which supplies remote locations with optometry services, and a notable Indigenous-specific policy are the Indigenous Chronic Disease Multidisciplinary Teams, part of the Medical Specialist Outreach Program. Hopefully these and other future policies will help reduce rural health inequality in the future. Mark will now move on to an explanation of the health workforce in Australia.
In Australia, we have high expectations of our healthcare system, as we are used to being served by a quality health workforce. However, will it continue to be of the same quality when our population increases and the demand for healthcare workers increases? The Australian health workforce ties into all of the topics mentioned into this video, as it is a product of all of them, and it is how the public receives its healthcare. The health workforce is a big industry in Australia, as 10% of all Australians employed work in health-related jobs. Alright, so some of the strengths of the health workforce. The health workforce in Australia is large, and it's also culturally diverse, meaning that individuals who cannot speak English will still have access to our healthcare system. This will make them feel more comfortable when visiting health professionals, and they'll be more likely to take their advice. The health workforce covers several occupations, as it ranges from highly qualified specialists and people who assist them, such as their support staff as well as their volunteers. It is also very specialised, meaning that the Australian public will have access to all kinds of different services depending on their illness or injury, rather than just visiting a local GP. Some weaknesses of the health workforce are: Australia has a high level of dependence on internationally recruited health professionals. It is one of the only countries doing this, so we need to put more resources towards our own citizens in order to make our health workforce more sustainable in the long term. Another weakness is the closure of the Health Workforce Australia in 2014 meant that momentum was lost in understanding and measuring the health workforce of Australia and the development of our future workforce. This could set us back, because if research is not being done, it makes it harder to improve the efficiency and distribution of the health workforce, such as distributing a certain number of health workers to rural and remote areas. It is harder to determine how many workers are needed in these areas without the research of the HWA. So we may employ too many or not enough workers to the rural areas, which makes the health workforce less productive. The last weakness is, in regards to the rural health workforce, there needs to be integrated regional training networks. They are already in some areas, but not all areas. The networks will provide education and training in rural areas, so ensure there is coordination in these areas. And next we have complementary and alternative medicine.
Complementary and alternative medicine, also known as CAM, has been seen as the new upcoming medicine in today's society. It provides a wide range of health treatments that provide holistic healing to the body. Many individuals are resorting to alternative and complementary medicine to treat chronic illnesses such as headaches and back pains. Complementary medicine works alongside with other medical care and other treatments such as acupuncture and chiropractic services, whereas alternative medicine is known to replace conventional medicine that is used independently, such as consuming dietary supplements and specialties to improve their health and well-being. CAM places less strain on the public health system, as it is not covered under Medicare, which is seen as an advantage. Individuals who have been experiencing chronic illnesses are able to seek other alternatives in treatment to reduce symptoms and pain. Some flaws CAM may have is that it is not available and affordable for all Australians, as it is an out-of-pocket expense for individuals who do not have private health insurance extras cover. Many individuals may not know about CAM due to the lack of research that has been done with no supporting evidence on the success rate of CAM. The National Health and Medical Research Council is currently assisting Australians to consider the potential benefits to CAM. To provide more information to all Australians about CAM, the Council is establishing resources for clinicians to discuss the use of CAM with patients, increasing funding for research on CAM to increase knowledge for all Australians, and evaluating the effectiveness of CAM by assessing evidence. Thanks for watching. We hope you are now more informed about the Australian healthcare
Primary
system.
healthcare is the front line of the healthcare system. It is usually the first health service visited by patients and includes most services outside of the hospital. Its activities include health promotion, illness prevention, treatments of acute conditions, and management of chronic conditions. Primary healthcare involves a number of health professionals such as general practitioners, nurses, dentists, Indigenous health workers, pharmacists, and allied health professionals. Services are delivered in a number of settings including general practices, community health centres, allied health practices, as well as through telecommunications such as health advice phone services. Primary healthcare is a broad term which covers a range of services across public and private sectors. It is called primary for a number of reasons. It is generally the first point of contact a person will have with the health system. It is where most interactions with the health system happen, and being located in the community, they have a direct connection to people's daily lives, as well as being central in coordinating other services. One of the strengths of primary healthcare is preventative health. An important part of primary healthcare is health promotion and illness prevention, which impacts on the health system as a whole. A strong primary healthcare system is important in lowering hospitalization rates and the duration of hospital visits by providing more appropriate healthcare services in the community and outside of the hospital. Community health centers and community development programs can engage with people effectively and promote health and provide services such as support groups, food benefits, etc. Patients will typically engage with a primary healthcare service, which can then refer them to other services, for example, seeing a GP, then being referred to a hospital or specialist. Some weaknesses of the primary healthcare system include equity. Not all people can receive equal primary healthcare due to where they live, their ability to pay for the service, or their inability to access the service due to poor health. The growing population is also putting increased pressure on the health system, particularly primary healthcare. Along with the growing population, there are increasing rates of chronic disease such as diabetes, which the current primary healthcare system is struggling to cope with. A lack of funding is a constant problem for the health system, particularly primary healthcare services. A weakness of the primary healthcare system is the health workforce. Only 25% of health workers are involved in primary healthcare, which means the system is often understaffed. That being said, the primary healthcare system is changing. In 2014, the government ended the Medicare Locals program, which was a framework aimed at networking primary healthcare services. This has been replaced by Primary Health Networks, which is aimed at improving primary healthcare in Australia. As this has only been implemented in 2015, it is too early to say if this will be successful.